Our next presenter is Professor Robert Baker, who is Director of Cardiothoracic Surgery, Research Quality and Outcomes Unit at Flinders Medical Center in South Australia, Professor Baker has worked locally, nationally, and internationally, and is very reputable for his brilliant work in improving patient health outcomes after cardiac surgery. So today he will talk to us about Nido Cardioplegia in adult cardiac surgery. Are we there yet? Please join me in welcoming Professor Baker to the stage.
Thanks very much for that warm welcome. And I would really like to thank the organisers, Richard, for the opportunity to present at the meeting. I had my first Sanibel adventure last year, and it really is a fantastic meeting. And the speakers we've had this morning have just been awesome. I mean, we are so privileged to have heard some of those talks today. So this is going to be a little bit different, and I hope you come with me on the journey through my presentation. But basically, the brief I was given was to see where we're at with Nido Cardioplegia. We'd published a small study recently, and Richard picked up on that and thought, well, let's have a look at what you're doing. And we all know the history of Nido Cardioplegia, its role in paediatric surgery, how it came about, a patented product back in '95, out of patent in the mid-2000s, and now very much adopted in adult cardiac surgery. But there's limited RCT evidence, and there's limited registry evidence. I'm going to share that evidence with you in the next 25 minutes or so. Just by way of its penetration in my part of the world, this is the Nido use back in 2017, so it was less than 0.1% of patients. This is our National Cardiac Surgery Registry, so it encompasses nearly every unit in Australasia. By 2021, that was up to 11%, and our last data harvest in 23 that I had access to was 16%. So you can see it's a rapidly growing, and that's reflected in the US and other parts of the world. So the structure of how I'll go about talking about is I'll focus on the results from a lot of the publications. I'll talk about some of the problems that I see in the literature and how we might go about continuing to improve. This is the paper that's probably the first randomised trial that was published in adult cardiac surgery. And Nivad and colleagues, Dave Fitzgerald was one of the authors on that paper, suggested that the evidence from this study suggests Nido Cardioplegia used in routine adult cases may be safe and results in comparable clinical outcomes and can streamline surgical workflow. Now, that's a fairly solid conclusion. So I'm not going to go through the methodology of every paper I present, but I'll just talk about some of them. This was a study that was designed as a non-inferiority randomized controlled trial, all comers effectively CABG valve and CABG valve patients. After a planned interim analysis at 90 cases, they decided to switch to a superiority methodology, which in itself is unusual at that stage of the trial. And the primary outcomes they looked at related to myocardial preservation, and they had secondary outflows relating to safety and workflow. So it's a good paper. I'm a bit of I like to interrogate a paper and work out whether the methodology that they present to me is able to be reproduced by me or other people. Their detail on bypass was excellent. The detail on what they did with the Nido and whole blood cardioplegia was equally fine. These are their primary outcomes. So you could see in terms of their myocardial preservation outcomes, return of activity, defib, inotropic support. There were, for return of spontaneous activity and inotropic support and troponin measurements, which if you think back to their conclusion, they were saying were strong results, failed to meet the p-value that they'd accepted for the trial, which was a p-value of 0.001. The only thing significant was the number of cardioplegia doses, which if we go back to the methodology, by by design was always going to be significant. So it's a really irrelevant result. So the central message was that evidence from this initial trial suggests the use of Nido Cardioplegia in routine adult cases may be safe and have comparable clinical outcomes and streamlined surgical workflow. I suggest it probably doesn't meet that goal. This is another randomised paper. This one's from Spain, looking at Nido in adults again. This is a cohort of just aortic valves. Similar primary endpoints, similar secondary endpoints. Another well-written paper. Oops, sorry. Yeah. There we go, sorry. Yep. And this is their summary graphic. And the bottom line is that they weren't able to show differences in their primary outcomes. They did see a little bit of improvement with glycemic control, and there was some evidence in relation to ischemic cerebral events. So there was some, they found some outcomes, but none of their primary measures or primary outcomes were significant. So again, they thought that this provided evidence for the use of Nido Cardioplegia in adults. Now, Professor Landoni kindly did a meta-analysis on adult cardiac surgery for us, and he shared a number of his previous meta-analyses, so it's very kind of him to be in the audience today. Basically, they reviewed about 10 papers, and this was their primary outcome. This was an interesting review, meta-analysis, in that the primary thing they were looking at was the effect on the brain, stroke and TIA. And it's not the automatic thing we think of when we're looking at outcomes for Nido Cardioplegia or any cardioplegia trial. But they found that there was a significant benefit associated with Nido Cardioplegia. If you look at the more traditional metrics, again, they found some benefits associated with Nido Cardioplegia in relation to VF, in relation to AKI, in relation to transfusion. So this is setting up a nice background for us to suggest, okay, things are going along pretty reasonably. Their summary was that reduced stroke, reduced aortic cross clamp, reduced need for defib, and reduced AKI. End of story. This is another meta-analysis. This one was published this year, and it focuses on coronary artery bypass graft surgery. So I should point out that the previous meta-analysis was an all-comer, so there was a variety of different papers. This is a more focused meta-analysis. So this meta-analysis evaluated the safety and efficacy of Nido compared with other conventional cardioplegic solutions in 24 studies involving nearly 35,000 cases. I think the original meta-analysis we talked about was about 1,700 patients. So this looks pretty exciting, doesn't it? I mean, that's a big number of cases. If we look down the list of studies there, we can see there's one study that stands out, and it's the observational study with 28,000 cases. So we'll come to that in a minute. But if we look at the randomized trials and we look at the propensity match studies, we can see that in reality there's about 720 patients in RCTs and about 1,600 patients in propensity match studies. So to me, that's probably what I'm going to focus on. In their meta-analysis, they actually did this as their subgroup analysis. Excuse me. And they found that there was no significant effect in their meta-analysis with respect to the operative mortality when you looked at the combination of all the data. Now, I mentioned that one of these studies was driving a lot of the meta-analysis. And it was really actually quite interesting because their method section said, in our subgroup, we'll look at randomized trials and we'll look at propensity studies and we'll look at one multivariate study. And the reason we included one multivariate study, obviously, was to get our N value up nice and high. So this is the paper. It was written from the PERFORM registry data. It's an all-comers paper. As I said, 44,000 patients in the whole study. Their outcomes focused on operative mortality and other SCS outcome measures. They also looked at transfusion and a few other metrics. And there's summary graphic you can see here. And basically, if you look on the what is your right-hand side, I'll just blow it up for you, you can see that looking at the risk-adjusted outcomes, there were no significant findings in any of the groups. So they broke it down to the aortics, the cabbage valve. So a lot of cases, risk-adjusted model, and this was their outcomes. So in their discussion and in their conclusions, they highlight two things. One is in coronary artery bypass graft surgery, they were worried that there might be a trend towards mortality. And in their aortic surgery, they were worried there might be a trend towards renal failure. And they suggest that warranted further investigation. Being an easily led person, I felt that my access to some registry data would allow me to go down this pathway. So I specifically wanted to look at two questions. One was, does del nido increase the mortality risk with cabbage? And the second was, does it increase renal failure in aortic cases? So we started off by looking at the ANZ CPR, which is our perfusion registry. And I sort of pretty well got that all done. And then I gained access to our National Cardiac Surgery Registry. So I was able to go from 14,000 cases to 73,000 cases. So the first piece of work I've put on the side, and I'm just looking at the surgical registry data now. And we were able to propensity match 16,000 cases. So that's a good solid cohort of patients. Operated between 2019 and 2023. We left off those first tentative years when it was just a few centres and a few cases being done. And then we propensity matched, and you can see the list of variables that we matched with. And what you match in a propensity study is very important. And you'll see I've underlined the last element there, which was year. This turns out to be incredibly significant in a study like this, a propensity study where you're looking at the adoption of something like Nido Cardioplegia. Because what actually happens is in the early years, people are looking at, oh, we've got this really bad case, so let's try this new way of doing things. And there's a lot of bias towards case selection in the early years of adoption of something like this. So I'm just going to share some simple graphs with you now. This is all comers, everyone's data prior to propensity matching. And you can see there's some significant differences between the two patient cohorts. Now, after propensity matching, you can see we've matched up pretty well. Now, looking at the outcomes, you can see that if we just took the data at face value, put it out there, you'd see there's massive differences between the outcomes with Nido Cardioplegia and whole blood cardioplegia, and they're all in favour of whole blood cardioplegia. Pretty well all in favour. If we now look at the matched outcomes, you can see that those outcomes have evened up considerably, and the Nido results are very similar to the whole blood cardioplegia. You'll see that there is a significant difference with pneumonia and with ventilation for greater than 24 hours in the ICU. I will point out that bypass time and cross-clamp time were shorter in the Nido groups. It seems to be something that people really want to have in the literature. I don't personally see 3 minutes as being a big deal. Okay, let's look at cabbage. So again, propensity match, 2,500 patients in each group. And you can see that after propensity matching, they were nicely balanced. Looking at the outcomes, we can see there's a pneumonia difference and there's a slight increase in AKI, absolutely no signal in terms of mortality or stroke. And I got to learn how to do forest plots myself. and used the data from the other meta-analyses and then slid our data in there as well. And you can see that the odds ratio is less than 1 and it's not significant. So there is no signal that Nido Cardioplegia is better or worse in terms of mortality as an outcome. And if we just look at the randomised studies, it's even, well, but there is no difference. I won't go down that rabbit hole. Okay, now looking at aortic surgery, same deal, we were able to match nicely, 2,500 cases, so a good cohort of cases. And again, in terms of outcome, nothing in mortality, nothing in stroke, and again, a pneumonia and a ventilation difference. So I was trying to work out, how do you summarise something like that? 10 minutes I've got left. Thank you. How do you summarise something like that? So what I did was, those significant results at a p-value of 0.001 I've put in red, and those that were sort of just significant I've blackened off a little bit. And you can see that in terms of mortality, in the valve cabbage cohort, which I haven't presented because it's quite a small cohort of about 600 in each group, there was some difference in terms of mortality, but I'd like to see a lot more data. Isolated DSWI, but pneumonia consistently more prevalent in the Nido groups. The relationship with ventilation, pretty consistent. A sporadic AKI and a sporadic length of stay in ICU, which can often be due to other things. And as I said, the bypass and cross-clamp times. So I think in the context of this work, it does add to our understanding of where we are with Nido. It appears to be safe. So what else is going on? Well, I love this quote from Sundar Ganathan. This was back in 2021. There are, however, unanswered questions. This is in relation to Nido. The most critical problem is the definition of Nido solution. There are more than 300 formula variations introduced under the same name with definitely different chemical composition. The safe duration of protection for Nido Cardioplegia is also unclear. So there are two things that we can look at in addition to this concept of variation, but dosing and prolonged strategies of delivery. So if we think about the literature, you go to all these papers and you'll see very nicely they publish their Nido and their blood, and they say to you, well, just take it for granted we're doing the right thing. And if you drill down into those, and I'm sure you know, if one wanted to, you could do a whole presentation on just the variation in Nido cardioplegias that are in the literature. So that's a bit of a problem. But equally, the problem is, what's the control group? I mean, none of these papers have the same control groups. And look, it's not just a problem for the published literature. It's the same for registry studies. I mean, think about it. It's not something that a registry can drill down on. Now, if we look at composition and delivery, these are two papers published a couple of years ago now, both out of New York, and they raise some really interesting questions. The first one, looking at redosing, used the mouse is here, used a novel strategy for its second dose. They reversed the ratio from 1 part blood to 4 parts crystallized with Nido to 4 parts blood and 1 part Nido. And they actually published that they had equivalent results. That one's an interesting study just to make you think about what you're doing. The second one, I think, has had a big impact on a lot of adult cardiac surgery. This was a study that looked at when you gave Nido in cases where there was an extended cross-clamp time. And in this study, they combined routinely antegrade and retrograde, that's shown by the red and blue arrows. And then as their redose, they made sure they redosed retrogradely every 30 minutes. Their outcome measure was an echo measure of LV function, and they were able to show that that was independent of time under cross-clamp. So they were able to clearly show that they were getting good protection. So there's been a big variation in how this has been applied and what people do. But the important thing was people were thinking about it. So looking at those cases with prolonged cross-clamp times, I'm going to share two papers. One is a paper published in JTCVS last year, and one's from our own group published in JECT. But I think the perspective statement for the Wilkes paper really sets the field nicely. Although the safety and efficacy of Del-Nido has been described in a variety of adult procedures, few studies have examined its use with longer myocardial ischemic times. And we really need to understand what the outcomes are in those cases. In the Wilkes paper, they were able to propensity match about 500 patients, and they found no differences in outcomes when they had a protocol of delivery that was a 60-minute and then a repeated dose in these extended cases. And I'll just skip that, sorry. We found very much the same outcome in ours. We had 388 matched patients. We were looking at myocardial outcome in terms of mainly troponin T and secondary death and stroke and stuff. But we a priori did this as a equivalency analysis. That's what we thought would be important. We can see here in the troponin outcomes, for all the different ways you can look at your troponins, you see your traditional p-value, then you look at the equivalency and you can see that statistically they are actually showing that the results are the same. And I think that's important that people think about equivalency rather than just comparing in a traditional framework. So yeah, and in terms of outcomes, there was nothing else going on there. So they were two studies looking at these prolonged cross-clamp times. This is a really new trial published this year. It's from a Chinese group, 112 patients in each arm. Now, I did mean to blow this up for you. I forgot about it. But you'll see there's two groups there. There's 448 patients. It's divided into two groups of 224, split as a high and a low Euro score. Quite amazing that you could get such a split out of that cohort of patients. But that being the case, they showed no differences in troponins or intraoperative outcomes. So again, we're getting that same message. Okay, I just want to finish by looking at what sort of a common question, or certainly was when Del-Nido started into the adult sphere, and that was lidocaine toxicity, and was that an issue in adults? And in this paper, they were able to clearly show that whilst there is a weak relationship, it wasn't going to be clinically significant. And they actually said that in adult patients undergoing cardiac surgery, procedures with lidocaine-containing cardioplegia solution, serum lidocaine concentration wasn't an issue. So that's an important safety finding for us. So are we there yet? I'd say absolutely not. I don't think we've got nearly enough good evidence. We're experience rich. I mean, it's being used daily everywhere, but we just don't have the scientific basis for what we need. And I think some more good RCTs and possibly RCTs in the framework of our registries, which is a technique that really would work well in our space in cardiopulmonary bypass, is probably what's needed. I'll just share, this is a sunset on my farm back home, and I'm just sitting on the front veranda, and I've just taken a shot just to share with you all today. So thanks very much for your attention.
Thank you, Professor Baker. That was a very informative talk. While people are getting recharged with questions from the floor, maybe I will start. We have trialed, at least in preclinical studies, to look at Del-Nido solution versus regular cardioplegia solutions on the microcirculation. We haven't seen any difference, even in internal organs like the brain or kidneys, at least in our models. But I was very curious to see that effect on increased risk of pneumonia. So I wonder if cardioplegia, what the effects of this is on the immune system. Like, is it immunosuppressant? I mean, is there any literature on that at all?
Yeah, I'll be honest, I haven't had the opportunity to delve in there. That's, I was literally gained access to the data set about a week ago. So I'd done the work with the perfusion registry data, but once I got access to the bigger data set, I had to use that and share that. So I really haven't had a chance to look into it. And, maybe Professor Landoni would comment on the likelihood or what a possible relationship could be. That's something to explore.
Well, just one question in terms of, we talk about dosing strategies. One of the things that was always postulated about, obviously, whole body cardioplegia, was that because you gave multiple doses of it, you had essentially an ischemic and then reperfusion injury occurring several times. Is there anything out there that says, when you've looked at, comparing apples and apples, if you like, so compare them both at the same dose length, is there much in there that suggests there's a potential for this to be a problem?
That's a really interesting, observation to think about, comparing when the strategy of delivery has been the same. There is so much variety in the papers that look at this topic. Down to, there's some real issues. One is editors. Editors aren't strict enough in asking for the detail about what's going on. In a study that looks at Del Nido versus some form of other cardioplegia, it's absolutely essential that we get shared all of the information about what's going on, because you just can't make meaningful interpretations. When you get a big data set, like the one I've shared, you do have the opportunity, some of that variation is taken away by sheer numbers. But it's really important to understand what's going on, and we don't have that clarity.
Okay. Great information. I was interested in the comparison between the Buckberg and the Del Nido, that there was no variation and the outcomes were exactly the same. So that was interesting to me, how we're replacing blood with a crystalloid and it still works. So it's always intrigued me. At the institutions I'm going to, they're using a lot of Del Nido and they're using large volumes. They're going above the 20 mils per kilogram. And so what I do see is once we take the cross clamp on, it seems to be a longer period of time before the heart recovers and we get a cardiac rhythm. I don't know if it's related to the large doses. We're doing a lot of hemo concentration because we're giving up to, like, believe it or not, 3 to 4 liters of Del Nido during the cases, which seems extreme. Without a heartbeat, they just want to continue to keep giving it and give a large dose right off the bat. So they're reinventing the way they approach it right now. So I just wondered if you've seen any issues with that, and I also wonder post-operatively, is there any differences with outcomes down the road, as far as the heart? I was seeing like a reperfusion injury or an issue with myocardial function in that respect. Thank you, sir.
So I'll address the intraoperative comment first. We've never been a high volume cardioplegia delivery centre, and the concept of delivering 4 litres of anything as cardioplegia is way out there for me. And if you think about when Del Nido really hit the adult stream, there was a big concern about the increase in rate of having to hemofilter on bypass to get that fluid off. And then there's some conversation around, is hemofiltration good or bad? But in our centres, we a priori do a standard 1,000 mil induction, and then if it's going to be a long case, anything close to being a long case, we'll redose at 60, and then redose periodically after that. So it's really important to have the team discussion and really understand how long that case is predicted to be, and that's where, in the future when you hit your pump, our AI models will say, okay, this case with that surgeon, that anaesthetist, and you is going to take this long. This is what you should be doing. So that's just a few comments about that. Post-operatively, we do troponin profiling on our registry, so you can just tap a link and it gives you the profile for every, for the case, well, for your patient, I should say. And my observations are that the profiles with Del Nido are very pretty. They peak nicely at that 12 to 24 hour mark, and they have a good tail coming down, unless you've had some clear intraoperative event. We're not seeing locally any big issues, and I think our experience is reflective of the literature in general.
Rob, Can you hear me?
Yep.
Courtney Peterson. This is really just a question of your experience. I had surgeons over the last decade, I feel like, nervous to redose. So if they thought they were going to give another dose of Del Nido, we would switch to micro. Do you have any experience with using two different plegias in one case, and do you think we should look at that closer?
Yeah, look, that's a really interesting question. Surgeons are a funny bunch of people, and they rely on us a lot, and yet they think they have independence and they can do what they like. And you're talking about that independence very much. You know, my strategy, our unit strategy has been a single style of cardioplegia, but we've had surgeons who, especially in the early phase of their Del Nido experience, after you had that initial dose, they wanted to revert back to their comfort zone. And there's no literature to support that, and there's no studies that have looked at it. Whether the outcomes were good or bad, it's just impossible to tell. So I can't answer your question other than to say, yes, I've had that experience. And no, it's you know, one of the things that is paramount importance as a perfusionist is safety. And changing cardioplegia strategies mid-case is a danger. It's not a safe practice. Even though you might say, oh, look, it's only 2 clamps. You know, in our circuit, it's just the blues are open for Del Nido and the reds are open for blood. But you can make mistakes, and they happen. So it's not good.
In the interest of time, we might move on. Thank you so much, Professor Baker.